where we can learn a lot. And without no further ado, Orrin, please go ahead.
Thank you very much, Dennis. I appreciate it. So I'll be reviewing the topic of sudden unexpected death in epilepsy, or SUDEP. And to begin with, while I will be focusing on SUDEP in this talk, it's important to recognize that premature mortality from a variety of causes is quite prevalent in epilepsy. And overall, people with epilepsy have an about 11-fold higher rate of dying young than the rest of the population. In one beautifully studied childhood onset epilepsy cohort from Scandinavia, they looked at people 40 years later from a small community. And what they found that of those people who died, 55% of the deaths were from epilepsy, with SUDEP being about a third, together with status, and then drowning 10%. So again, epilepsy is a common cause of death. SUDEP is just one of the mechanisms. In another study done in the United States in Ohio, where they looked at people on Medicaid, which in general is associated with lower socioeconomic status, young adults died 10 years prematurely than other young adults, 17 years prematurely. Now that's a remarkable statistic, because if you look at everyone who smokes a pack a day of cigarettes, the average reduction in mortality is about 10 years. So being poor in the United States and having epilepsy is almost twice as deadly as smoking cigarettes for your life. There have been some other studies that looked at causes of death in epilepsy. This is a European study by Fasel. And natural causes of death were 15.5-fold more common. External causes, and that's really a medical examiner coroner phrase for things like suicide, motor vehicle accidents, drug poisonings or overdose, falls, drowning, and assault, are all significantly more common among people with epilepsy, and notably for this group, the majority have a psychiatric comorbidity. But when you look at the incidence of a sudden unexpected death among people with epilepsy, the frequency is about 27-fold higher than the general population. And among studies, the frequency of SUDEP varies quite a bit as far as causes of epilepsy-related death. Overall, if you look at a number of studies, it comes out in about the range of where that previous article from Scandinavia I mentioned, 35, 45%. Although in some studies, like the Medicaid study, it was a very tiny percentage, under 5%. And this excludes, keep in mind, other causes of epilepsy-related mortality that don't even come into the issue of epilepsy-related deaths. So bronchopneumonia, people who have seizures can have an aspiration of the contents of their stomach or mouth into their lungs, which can cause pneumonia. Not surprisingly, dying of bronchopneumonia is about 7-fold greater among people with epilepsy. Suicide, we know depression and suicide are markedly elevated among people with epilepsy, but we don't count those as epilepsy-related deaths. So again, the mortality in epilepsy is an enormous problem. It's always good to think about people. Often we talk about statistics and numbers, but this is one young man, 21-year-old. Seizures started when he was 13. Just had a handful of seizures by the time he went to college. He was a star baseball player. He was seizure-free after his sophomore year in high school until he died suddenly 2 years later in college. So he basically was never warned about SUDEP. His parents were never warned about SUDEP. It was never clear to him if he stopped taking meds for a week, if anything worse than a breakthrough seizure could happen. The family was never informed of any research opportunities. And we now estimate there are more than 3,000 deaths like Chris's every year in North America, and more than 60,000 worldwide. And this is the story of SUDEP. So how do we define SUDEP? It is a of death, whether it be structural, something like a heart attack or cancer, or toxicological, something like cocaine poisoning. It is definite when there is an autopsy and there's no other cause identified. It is probable when the setting is typical, but there's no autopsy done. And it's possible SUDEP when there is an alternative cause of death and clinical data are lacking to make a clear definition. There is a research definition of SUDEP plus, and that's evidence for a condition before or after autopsy, which could have been contributory together with a seizure and SUDEP to the cause of death. So it might be something like coronary insufficiency without a heart attack, prolonged QT syndrome without a documented ventricular arrhythmia. Potentially here you have a seizure. The effects that we'll talk about later could be contributory together with these other factors. So what's the frequency of SUDEP? And this looks at a number of studies grouped together. And the classic teaching, which I'll tell you has come under some questioning, is that SUDEP is very low among children. The rate here is under 1 per 1,000 patient years. And again, I think we need to give those numbers meaning we can deal with. So if you look at this graph, if you just look at large population studies, it's also quite low, under 1 per 1,000 patient years. People with epilepsy in a mixed epilepsy clinic can get up to 2 per 1,000 patient years. Those with what we now would refer to as intellectual disability goes higher. People with treatment-resistant epilepsy and those who go for epilepsy surgery get in the range of 6 per 1,000 patient years. What does that mean for an individual? It means if you're a 20-year-old with uncontrolled seizures, which include tonic-clonic convulsions, the risk of dying of SUDEP is probably about 4 to 6% per decade. Now, keep in mind, that's probably 50% of direct epilepsy-related mortality. So other causes like car accidents, falls, burns, a variety of other problems related to seizures can also be deadly. So it could be up to 10% a year for some of our more difficult patients to die directly as a consequence of having epilepsy. So this is a recent study which will hopefully come out in one of the major neurology journals shortly. It is from Sweden, and they looked at everyone in Sweden who died in 2008. And among the 58,000 roughly epilepsy patients, a little under 1,900 died, 3.3% of that group. There were 99 SUDEPs identified in that population. They were 5.2% of all deaths. And notably, 36% of deaths among children up to age 15. The incidence of definite or probable SUDEP was about 1.2 per 1,000 patient years, and a bit higher in men than women. All the SUDEP cases, and I think this is just chance, under age 16 were boys, and the SUDEP incidence at different ages was under 16 was 1.1, 16 to 50 was 1.13, which is typically considered the peak incidence, and was 1.3, or just below that, among those 50 years of age and older. So what are some of the risk factors from people who died from SUDEP to those who don't die from SUDEP? And in a number of studies, the number one risk factor are frequent seizures, especially generalized tonic-clonic seizures, and seizures that occur during sleep. A symptomatic cause for epilepsy, such as a previous head injury, stroke in the mother's womb, or subsequently, something like that increases risk. People who don't take their medications regularly or are prescribed low doses that don't provide adequate levels, individuals with multiple medications for seizure control, which may just indicate a severe type of epilepsy, early age of epilepsy onset with long duration of epilepsy, male sex, and intellectual disability. Factors that correlate with a reduced SUDEP risk include seizure freedom, sharing a bedroom or supervision, and the recent addition of a seizure medication, an anti-epileptic drug. So this was a landmark study that I think woke many people up, done by a colleague, Philippe Rivlin, now in Switzerland. He looked at all the epilepsy trials for drugs that eventually got FDA approval. And if you look at the cases during these are adjunctive studies, so someone might be a patient on 2 seizure meds, but they're still having seizures, so they get randomized for 3 months to either receive a placebo in addition to their 2 drugs, or another medication which eventually gets approved because it's effective. So if you just look at that top line, which I think will summarize the gist of this study, in 11 trials, if you were randomized to receive an active medication compared to the group that was randomized to receive placebo, your chance of dying from SUDEP was only 10%. So if you got the placebo, you were 10 times more likely to die during those 3 months than if you received an active medication. And what this tells us is seizure control can prevent SUDEP. And we've got the smoking gun from many places that I'll get to, but I think this study really told us that this is a significant and class 1 evidence for this phenomenon. So what are some of the other factors that I mentioned? Well, the vast majority of SUDEPs are unwitnessed, and we don't think this is a coincidence. They often occur in sleep, where people sleep alone. These are going to be the people who tend to be at high risk. Why is that? Because with some seizures, the seizure itself may cause a person to roll on their belly with their face down, often in the bedding. And after the seizure, we'll get to some of the mechanisms, but one of them is that the brain is essentially in the off position. And breathing does not occur without the brainstem. And so after a seizure, there's a period where the reflexes to wake up are impaired, breathing is reduced or absent, and if that combines with a bad position, that may be the critical factors that allow the person to die. If someone was with the person and simply witnessed it and rolled them on their side and stimulated them a little bit, that may have saved their life. So the history of nocturnal seizures is significantly associated with an increased risk, an observed risk of about 3.5 times. Compared to living controls, nocturnal seizures increase the risk of SUDEP death about 4-fold. And prone position is very commonly, that's on your belly, associated with SUDEP, especially in patients over age 40. Well, what do we think is going on? What causes SUDEP? And the vast majority of the evidence points to a terminal seizure, usually a convulsive tonic-clonic seizure. And of the witnessed cases that do occur, about 90% are preceded by a witnessed seizure. Usually the seizure is followed by a period of difficulty breathing, and that seems to be it. We also have markers on pathology that would also point to evidence of a seizure, heat shock protein 70, but the witness cases speak to it. And then perhaps most importantly, we now have 11 cases that have been published in the medical literature of SUDEPs that occurred in a hospital epilepsy monitoring unit where we have an EEG and EKG typically going on these patients. And there have been 9 near SUDEPs where people recovered due to intervention. 9 of those followed a tonic-clonic seizure, 2 after a complex partial. So essentially, of the SUDEPs that have occurred, the vast majority, all those recorded in these studies, followed seizures. However, I should say it is possible for SUDEP to occur without a seizure. There are other mechanisms, but this is by far the most common. And the 3 things that occur after a seizure is 1, the brain shuts down, 2, there are respiratory problems, and 3, there can be cardiac arrhythmias. Although we thought cardiac arrhythmias were the main cause 25 years ago, in none of these cases did it appear to be the primary factor. So what is this concept of cerebral shutdown? So after a tonic-clonic seizure, the EEG can go flat. And during that time, the patient is essentially in a coma. You could take your knuckles, put it hard into the patient's sternum, and they would show no arousal response in many cases, showing the impairment in the arousal and normal responsive reflexes that we have if someone to do something like that maneuver. So in one study by Sam Latu and colleagues, they looked at cases from Case Western that were monitored in a unit and later went on to SUDEP and compared them to controls who did not die from SUDEP but also had monitoring. And if the duration of postictal generalized EEG suppression, which you can see on this right half of the image here is this flat line, there's some movement here, but this is really a motion artifact. This is the EEG here. And unlike the end of the seizure here, this is muscle activity. And at this point, there's no muscle and there's no brain activity. The risk of SUDEP goes up 30-fold in this study when the duration of postictal generalized EEG suppression is more than 60 seconds. This has not been replicated by all studies to this date, but there's a lot of differences in methodology. And of course, now nurses should be attending to patients rapidly after a seizure. And it turns out that intervention will reduce the postictal EEG suppression as well. So this is another study from Philippe Rivlin's group in France at the time. And what it shows is that the seizures with bilateral symmetrical tonic arm extension, which are the classic tonic-clonic seizures, or what he refers to as type 1, have an odds ratio of 66-fold greater chance of causing post-ictal generalized EEG suppression. And if the seizures occur in sleep, there's also a 5-fold greater chance of getting this EEG suppression. If oxygen is administered, PGES goes down, and if it is not administered, it goes up. So this suggests that the idea that there's nothing we can do about SUDEP is wrong. We can attack SUDEP and prevent it probably by better seizure control, better compliance, and more rapidly attending to people after a seizure. Of course, the great problem is those people who have epilepsy and live alone. What are some of the mechanisms? And this has been studied in animal models. Dravet syndrome is a human epilepsy where there's mutations most commonly in the sodium channel 1A gene that codes for the NAV 1.1 sodium channel. And mice models of this disorder can be used to study. If you heat these mice up, just like humans who have fever, they produce seizures. And what this study looked at was, here you can look at the time of death on the top and what's happening with EEG activity. Here's the EEG power over here. It shuts off going along with the post-ictal EEG suppression. Heart rate gets more variable, but actually is shown here. And towards the end of life, there is bradycardia that probably in these mice contributes at some level to the seizures. The bradycardia seems to be a result of brain sodium channels, not heart sodium channels, so it's the brain that's driving this. And this study is an important one. These mice can be rescued with atropine, which is an anticholinergic, which blocks the parasympathetic nervous system. So some parasympathetic hyperactivity, which may not just be affecting the heart rate, but may be affecting brainstem structures as well, appears to be a critical mechanism in this specific mouse model. How relevant this is to humans without sodium channel mutations is very uncertain, and even in those with sodium channel mutations, unfortunately, children with Dravet syndrome have rates of mortality related to SUDEP and prolonged seizures of up to 20% by age 20. Here's another fascinating study by Jeff Noble's group in Baylor, and they looked at mice with two different channel mutations, one in the potassium channel, one in the NAV 1.1, the SCN1A, and they gave 4-aminopyridine to the cortex. And what they found is that there's this brainstem activity that correlates with the cortical seizure, and then there's this DC shift. So not the classic alternating current of the EEG, but the DC, which is referred to as a slow spreading depression or depolarization in the back part of the medulla, shown in this figure here, which is very critical for respiratory activity. What's not clear from the study is if the spreading depression really is the mechanism of shutting off respiration and causing death, or if respiration may stop actually earlier than the spreading depression. But it certainly is an important model and tells us there may be different mechanisms. There's another animal model done by Peter Carlin up in Toronto, and that actually shows seizure spread. So this shows more of this spreading depression. Carlin's model of 4AP hippocampal seizures, a very different model, in rats showed actual seizure spread to the brainstem. So there are probably many different mechanisms that contribute. What can doctors do? One thing we can do is educate each other better. When I was a resident at Cornell about 30 years ago in neurology, I was told seizures don't hurt the brain, and seizures never kill people unless they're driving or swimming. That was wrong. I was taught wrong. And what's remarkable is that this gentleman, Dr. William Spratling, who was an American epileptologist at the turn of the century in 1904, wrote in his textbook that seizures destroy life suddenly and without warning through a single brief attack, and does so in about 3 to 4% of all who suffer from it. So he was well aware of SUDEP. It's a mystery why 75 years or more later, I was never taught about this during a neurology residency. So this slide looks at the epidemiology of SUDEP, and just a couple points to make. If you look at lost life years, now stroke causes many more deaths in numbers, but because most people who die from a stroke are in their 70s or 80s, the potential life years is relatively less. Whereas SUDEP often affects children and young adults, and so the potential life years lost is great. So SUDEP itself causes about half as many or more lost life years than stroke, but if you took all causes of epilepsy-related mortality, sadly, SUDEP is probably the leading cause. This bottom graph shows the age range, and this is from all the studies previous to the very well-done epidemiologic one in Sweden that I mentioned before, and this shows the peak age kind of between 20 and 50, which has always been the teaching and what we've seen in most studies. But it turns out that this childhood age is probably greater than we've recognized, and for some reason, we have not been counting it quite as good as we should have. Now, I think this whole number set that I'm presenting today is a dramatic underestimate. Many cases are not accounted for. Someone is 65 with epilepsy, dies suddenly in bed, sleeping alone, found face down. The autopsy is negative. It typically gets coded in the United States as a cardiovascular mortality. That's just a bias. They're going to have a little bit of plaque in their coronary arteries. They died suddenly in bed. They're 65. And most medical examiners in that setting will code the death, I believe, incorrectly as a cardiac or some other cause and not put epilepsy or SUDEP as the cause of death. So these numbers are conservative. Well, we've typically told parents of children with what are called benign epilepsies that they're the North American SUDEP Registry, or nasr. Among our first 189 cases, we found 3 children who have definite or probable SUDEP. And these were cases where the parents were told not to be on meds in 2 cases, or in one, both the doctor and the parent decided not to treat with meds. Probably medications just given before bedtime would have been life-saving. We don't know that for sure, but probably they would have. All 3 died in bed during sleep and were classic circumstances with evidence of a seizure before death. So again, we need to rethink what we call different things. So what as a community have we failed to do? Well, we still don't have good data on the frequency of SUDEP. And if we don't have good public health data, we can't measure interventions. We know exactly how many children die of SIDS every year. We've known that for 20 years. So when they did the Safe to Sleep or Back to Sleep campaign 20 years ago, we can show that the rate of SIDS has now dropped by about 50%. We can't do that for SUDEP because we have no idea in the United States what that number is in 2017. I'm afraid to say we're not terribly close to getting there. So we need to work better with the medical examiner system, and we've started to make steps in that direction. We need to educate our medical colleagues in neurology, general medicine, pediatrics. We need to educate patients and families so they know this is a risk, why taking meds is important. And we need to figure out ways to do intervention so we can look at the risk and study ways to reduce it. So this is a survey by my colleague here at NYU, Dan Friedman, and others. How frequently neurologists in America, North America, that's Canada and the United States, talk about SUDEP to their patients. And 12% never talk about it. 21% talk about it more than 50% of the time. So SUDEP education right now of patients and families is terrible. Do people with epilepsy want to know about SUDEP? The simple answer is yes. This is surveys done by both internet, epilepsy.com, and the clinic. And the vast majority of people learn about SUDEP from the internet. Only about 10% learned about it from their doctors of those surveyed on the internet. And about 20% of those surveyed in an epilepsy clinic learned about it from their neurologist or epilepsy doctor. So the vast majority of people who know about SUDEP learn about it from the internet, not from their doctor. Only 2 or 3% of people would never want to know about SUDEP. And so it does come up that not everybody wants to know, but the vast majority of people do want to know, and many believe it would help influence their management of epilepsy. So why does education matter? Well, think about it. About as many Americans die from SUDEP as from fires, and many more die than SIDS. Actually, SIDS is now down to about 1,650 in the United States. There are 300, this slide was a couple of years ago, I think we're up to about 330 million Americans. Pretty much everyone who's an older child knows about fire safety, and pretty much every adult has heard about SIDS. So for disorders that kill 1,500 to 3,100 Americans a year, every American seems to know about it. So how is it that the 2.9 million people with epilepsy don't know about SUDEP from their doctors or their public health agencies? What have we been doing wrong? Well, part of it is education, and part of it is knowing how to educate. And this has been studied for things like seatbelts. If you tell a teenager when they get their license, you know, one out of every 3.5 million person trips is fatal. That's just some random number that has no connection to them. But when they're told over 50 years, you have a 1% chance of dying personally and a 33% chance of being in this disabling accident, that does change behavior. And we need to take those kind of lessons and do the kind of nudging of behavior that has been done effectively in other places. We have just failed to even begin to take the initial steps in SUDEP. This is a slide from some of our work here at NYU, working together with the New York City Office of the Chief Medical Examiner. And as I said in that Ohio Medicaid studies, if you're poor, your risk of SUDEP goes up dramatically. And looking at SUDEP, it tracks with low socioeconomic zip codes, as shown in this heat map of New York City, looking at areas that are the most heavily affected by SUDEP. And again, thinking about national priorities, in the last 20 years, we've spent more than $500 million tackling SIDS, which now takes about 1,500 to 1,600 lives a year. SUDEP takes a minimum of 2,750 lives a year in the United States, probably more like 3,500. And we've spent NIH and CDC money less than $75 million in the last 20 years. Not exactly equal in priorities. What can we do to stop SUDEP? Well, we don't really know other than controlling seizures. We do believe, based on some studies, that if people are around, they're less likely to die from SUDEP. And we know from some people in England who lived in group homes where there's close supervision, those individuals die almost exclusively when they go home to their parents' house on some weekends where they're not supervised. Because when they're supervised, if a seizure occurs, one of the attendants in the group home or facility goes to the person, rolls them on their side, and attends to them. And that simple measure is probably life-saving in some cases. There are other things like pillows that would allow you to breathe, but no one's really studied them, and we just don't know. And then there are a variety of devices, including one that was developed by Roz Picard and her colleagues at the MIT Media Lab called the Embrace Empatica, which is a way, together with some of these motion detectors and other devices, to alarm other individuals in the apartment or home that a person's having a seizure and attend to them. And this is a recording showing electrodermal activity on the top, sympathetic nervous system activity. Here's the seizure, and here's the dramatic rise in EDA following the seizure. This person unfortunately died. The parents did not get the message. The phone wasn't attended to at that time, which is just can happen and extremely unfortunate. This would be normal electrodermal activity. And then this is respiratory rate, which was calculated, and temperature. But the point is, we now have devices that can activate phones or computers of a family member to warn them that someone's having a seizure and attend to them. Other things we've worked on is the North American SUDEP Registry, and this is a way to get more data. Those are those cases of benign Rolandic epilepsy we found, to partner with medical examiners to try to learn more about SUDEP, to get DNA specimens, which we're now have collected hundreds of these cases and are in the process of sequencing these brain tissue to look for what's going on in the brain using RNA sequencing and proteomics and other techniques to look what's happening in the brainstem and the cortex, and then to make this tissue and genetic data available to the wider scientific community. And to finish, I just want to touch briefly on the genetics of SUDEP. We don't know how important genetics is. It just right now is something that we found a variety of interesting findings, but we just can't say for sure. So we know for children with Dravet syndrome due to SCN1A, other sodium channel mutations with severe epilepsy like SCN2A and 8A, duplication 15q, that there are very high rates of SUDEP among these individuals. What we don't know is if the rate of SUDEP is high because they have severe epilepsy, or is there something specific about these genes that predispose these individuals to dying? There are some cardiac channelopathies like long QT2 syndrome, which is associated with seizures in the probands, and these individuals do have higher rates of sudden death and may result likely from a combination of both the seizures and abnormal cardiac physiology. But we really need a lot more data. And this is to date the best study that's been done, published last year in the Annals of Neurology by an Australian group, where they took 61 definite and probable SUDEPs, and they found de novo mutations or previously reported pathogenic mutations or candidate pathogenic mutations in nearly half of the cases. 4 of the SUDEP cases had mutations in common genes associated with cardiac arrhythmias. 9 had candidate pathogenic variants in other cardiac arrhythmia genes. And 15 cases had mutations in epilepsy genes. Now again, whether these, for example, DEP, DC5, DEPTIC5, and KCNH2 are really increasing the risk of SUDEP beyond the risk of having bad epilepsy remains uncertain, and that's one of the challenges for the future, and hopefully some of our ongoing studies will help answer that. So in closing, our failures, which I would say unfortunately at this time are numerous, create opportunities. And again, thinking about Chris's story that we started with, surveillance, we need to do better at a national CDC level and attack some of the problems like low socioeconomic status and healthcare disparities. We need to work better at seizure control with medications, diet, devices, surgeries. There's a lot of opportunities, and many poor people do not get access to therapy.